Well, thank you very much, and good afternoon to you all. It's really a tremendous pleasure and an honor for me to be here with you today. So the component that I'm going to talk about in the study for the next few minutes really brings together the two strains that we've heard about so far in looking at mortality and combining that with the non-fatal outcomes. And in that way, it very much builds on the hard work that so many people in this room and around the world have done on this study. So I'd like to start by joining some of the other speakers in just thanking the hundreds of people who've been collaborators and co-authors on this study and made it possible. Also thanking Richard Horton and Pam Dass and the team at the Lancet for communicating it to the world. So far this morning, we've heard about a number of different measures. We've heard about measures of mortality, causes of death, YLLs that capture premature mortality, and just now YLDs that capture disability relating to specific causes. In this presentation, I'll introduce another type of measure called healthy life expectancy, which is intended to be a very broad summary measure of overall health in a population that builds on the familiar demographic notion of life expectancy. So we start with life expectancy, which is calculated by computing the area under the survivorship curve, which traces the fraction of a birth cohort that would survive to different ages if they were exposed to some schedule of age-specific mortality. And the life table gives us a way to integrate under that curve and the familiar measure of life expectancy at birth. Healthy life expectancy extends the idea of life expectancy to deduct for time spent in poor health. And there have been a number of different ways that healthy life expectancy has been calculated. The simplest ways treat health as dichotomous. Either you have a health level that's above some threshold, in which case time spent counts towards the healthy life expectancy fully, or if you have a health level that falls below this threshold, that time counts not at all. Now, the measure that we've used in the GBD uses a more detailed accounting of the different health states that occur along a continuum from perfect health to death, and factors in all of the short-term or long-term losses of health captured in the 1,160 sequelae that you've just heard about. And so conceptually, you can think of this as starting with life expectancy, deducting for the time spent in short-term and long-term health problems, big and small, after weighting for the severity of the health losses associated with each of these. And in this way, we account both for how commonly different health problems occur and how great is the loss of health when they do occur. And so as a simple example, if people spend their last year of health with some range of conditions that reduce their overall health by 50%, then this last year only adds 6 months to healthy life expectancy. So one of the things that we've aimed to do by looking at life expectancy and looking at health expectancy and looking at changes in these is to think about how the experience of disability, its severity, its duration, changes as people live longer. And there's two directly contradictory hypotheses about this. One, called compression of morbidity, suggests that overall healthy life expectancy might rise faster than life expectancy if delays in death are accompanied by delays in the onset of disability. The opposite hypothesis is expansion of morbidity, which says that as life expectancy rises, it does so faster than the addition of healthy years. And these questions have been of great interest to scholars and researchers, but you can imagine also why they are of central importance to policymakers who are trying to plan for the needs of aging populations. So with that as background, the aims in our study were to use key inputs and estimates from the GBD 2010 exercise to compute healthy life expectancy for 187 countries at 2 points in time, 20 years apart, and using comparable methods to say something about patterns and trends and changes over time, and also to consider these hypotheses about the relationship between changes in mortality and changes in morbidity. Calculation of healthy life expectancy in the GBD used 3 primary inputs, and you've heard already about all 3 of these, so I'll review them rather quickly. The first inputs are mortality rates by age and sex. And as Alan presented earlier, these are based on first estimating child mortality and adult mortality, combining these with model life tables that had more or less flexibility depending on whether there were good vital records. The second component you've just heard about from Teo, which is to estimate the prevalence of the 1,160 disabling sequelae through a combination of systematic review undertaken by hundreds of experts, many of them here today, and through the Bayesian meta-regression approach to combining information across studies, across age, sex groups, countries, and time. And finally, disability weights estimated based on new primary data collection that you also heard about a moment ago from Teo, that included surveys among 30,000 respondents from around the world. So these estimates were combined using a standard approach known as Sullivan's method, which takes a prevalence perspective on health at different ages and incorporates that into the life table. To incorporate prevalence estimates for the nearly 1,200 sequelae into an overall measure of health, we used a microsimulation approach to account for comorbidities as they would occur under a simplifying assumption of independence. And we applied disability weights for single or multiple conditions in order to estimate overall age-specific YLD rates, which were then flipped on the 0 to 1 scale to get overall average levels of health into the Sullivan life table. So on to a few key results. Globally, life expectancy at birth in 2010 was a little bit less than 70 years for men, a little bit more than 70 years for women, with about 5 years difference between the two. If we think about healthy life expectancy, in particular how that differs from life expectancy, we see that men lost about 9 years of healthy life due to disability, and women about 11.5 years. Thinking about change over time, globally, life expectancy over the last 20 years has increased by about 5 years, whereas healthy life expectancy has increased by only 4 years, which means that the population today loses more years of healthy life to disability than it did 20 years ago. We can look across countries at the highest and lowest healthy life expectancies and see enormous disparities. Japan leading the world for both males and females with a healthy life expectancy of around 70 years. And at the other end, we see Haiti with less than 30 years of healthy life expectancy for men, less than 40 years for women. And this, of course, was an exceptional result in 2010 related to the January earthquake, with only 2 exceptions, Haiti being one, the other shown in the remaining bottom 10, but not here, was Afghanistan, the lowest healthy life expectancies, as you can see, in sub-Saharan Africa. Scanning the map, the patterns are fairly clear, with the highest values in the dark blues in North America, Western Europe, Australasia. And then you see this band of reds and oranges showing you the lowest values, and strikingly, a twofold difference between the highest and lowest values across countries. Those are results for males. I'm going to flip over to females, and you see another clear pattern, which is that the blues are a little bit darker, the red's a little bit lighter. In both cases, that tells you that female healthy life expectancy higher than male healthy life expectancy. And that's true in virtually every country. There's only 3 exceptions, Afghanistan being a prominent one. We can turn now to changes in healthy life expectancy between 1990 and 2010. And again, we see a story of extraordinary disparities across the world. Some countries saw tremendous gains, including Ethiopia, Angola, Rwanda, adding more than 10 years to healthy life expectancy over this 20-year period. On the other hand, healthy life expectancy for males in Haiti was 17 years lower in 2010 than in 1990, and there are big decreases in other places of 10 years or more, Lesotho and Swaziland. One thing that was striking to me when you look at the list of the biggest gainers and the biggest losers is that in many cases they're all in sub-Saharan Africa, and I'll come back to that point. But let's now turn to this question of how disability has shifted in relation to changes in mortality. And we can do that by looking together at life expectancy and healthy life expectancy, and specifically understanding the difference between these two measures as a measure of how much healthy life overall is lost to disability. So if you subtract healthy life expectancy from life expectancy, that tells us how much we end up deducting from life expectancy when we account for all these small and large disabilities in the population. So we can start by looking at a cross-section. In this case, these are countries in 1990, males on the left, females on the right. In each of these graphs, the x-axis shows you life expectancy at birth. The y-axis shows you the difference between life expectancy and healthy life expectancy. And what we see in this cross-section is quite consistent with expansion rather than compression of morbidity. And that is that countries with the highest life expectancies in 1990 were also the countries in which people gave up more years of healthy life to disability. That's true in 1990. It's true as well in the cross-section in 2010. And I think even more convincingly, it's true when we look longitudinally. And so here we just connect those dots with a line. And you can see the direction of this line moving diagonally up to the right suggests that those countries that have gained the most in life expectancy have also seen the greatest increases in the total amount of disability expressed as lost years of health due to non-fatal consequences. And that's a very consistent pattern, and I think one of the striking findings in the study. Final graph I want to show you very quickly is this one, on which we look across the 21 regions at the relative contributions of 3 different factors to overall changes in healthy life expectancy between 1990 and 2010. And those factors are mortality under age 5, mortality over age 5, and changes in the prevalence of disability. In this graph, the purple line at the boundary gives you the overall changes. And you can see that in nearly all regions, healthy life expectancy has gone up, the exceptions being the Caribbean and Southern Africa. In some regions, the increases are due primarily to reductions in child mortality. That's the green line you see there. In other regions, largely in high-income countries and parts of Asia, the increase is mainly due to reductions in adult mortality. But of note, in no region are changes in disability the primary driving force. And so let me end with a few remarks, first on some of the advances and the limitations in this study. The study adds to previous work in the area by building on the systematic, exhaustive review of epidemiologic data sources that so many people have worked on, by applying a standardized approach to measurement at 2 time points, and by building up estimates of overall disability through analysis of individual causes and combinations of these. There are also important limitations. Many of these you've already heard highlighted today, including data gaps in mortality, and especially so on the non-fatal side. While the compilation of so many data sources using a Bayesian approach is a strength of the study, it also brings to light the major uncertainties that there are, and in particular where we've borrowed information from some settings that have data to extrapolate to others that don't. There's the possibility that we're underestimating the true variation that occurs across settings. In terms of the disability weights, you've heard a little bit about the limitations. We've heard a lot more from many of you. The validity of the weights do depend on the validity of the descriptions we have. And we've already identified then a major research agenda moving forward to improve the match between the epidemiology and the health state descriptions, and to really expand the empirical basis for understanding the distributions of health states related to particular sequelae. So I'll leave you with just a few summary points that I think arise from this analysis of global patterns and trends in healthy life expectancy. First, I think the headline result is that healthy life expectancy has increased more slowly than has life expectancy over the last 2 decades, which is a story of great progress in reducing mortality, but of much less progress against disability. And so for individuals around the world, I think there's some good news and some bad news. On the one hand, people can expect to live longer lives, including additional years that are spent in relatively good health. On the other hand, Peter Piot wants to die healthy, as many of us do. And unfortunately, people can also expect that the extra years that they add will include a range of ailments. that are very common in aging populations. So some of the time that's added will be extra time in poor health. For policymakers, I think the implications are quite profound and profoundly important, which is that we can really count on an overall significant increase in the total volume of disability virtually anywhere in the world. And that's already dramatically reshaping healthcare needs, social and financial costs, and demands on the health system in terms of infrastructure, in terms of human resources, in ways that will continue and will worsen. Most gains in healthy life expectancy over the last 20 years have been due to reductions in child-adult mortality. The detailed analyses of YLDs that Teo presented to us allows us to unpack the contributions of major causes of overall disability. And we can see a relatively small number of causes that are very much driving the disability transition: mental and substance use disorders, musculoskeletal conditions, and a few others, that they simply have not seen significant improvements over the last 20 years. So we hope in the end that this study will alert people to this major disability transition underway, from mortality being the primary driver of burden to disability being more and more so. And I think this really highlights that the time has come for a more balanced approach to health priorities that includes much more attention to the need to reduce the prevalence and impact of major causes of disability. And so we hope this study gives us a starting point in thinking about a detailed description of the patterns and trends in major health problems as we together move towards looking for effective and affordable solutions to these. Thank you.